I'm Dr. Megan Curran. I work at the University of Colorado at Children's Hospital Colorado. Patients come to us having struggled with getting a diagnosis for a little while. Some families get a diagnosis of dermatomyositis from a non-pediatric rheumatologist. I would imagine that many patients have to eventually get to a pediatric rheumatologist to get the diagnosis. I firmly feel like any patient with myositis should be treated by a pediatric rheumatologist. Even pediatric rheumatologists don't always know how aggressive to treat myositis. And we worry because we don't want to harm patients by over-treating them. We don't want to over-immunosuppress. But with myositis, it's important for us to make sure that we understand how active the patient's disease is so that we're screening appropriately. There are studies that show that the longer a patient has a delayed diagnosis, the harder it can be to treat their condition. I would say the first step is you want to make sure that the extent of their condition has been assessed appropriately. In myositis, we like to use standardized instruments. We would want to do muscle testing, so strength testing, like the CMAS, where we have the patient lie down and sit up and hold their arms up and hold their legs up. We will want to look at their skin very closely, take pictures, and then there's lab work and imaging. So all of that to kind of describe what's going on. It is standard of care nowadays to do an MRI when muscle enzymes are normal, and if a rheumatologist is not wanting to do that because the patient seems strong and the numbers are normal, but they have rashes that are dermatomyositis, that is definitely a reason to get the muscles imaged. A myositis kind of expert or someone who has that focus might be thinking a little more broadly about more tests. Finding that sweet spot in terms of the right amount of medication to start in the beginning sometimes is hard for us. Being reevaluated, making sure that you're actually getting back in for a follow-up visit. I definitely see my myositis patients with a new diagnosis back in a month. It's really important for us to see how they're responding to their initial treatment, and if their disease is not responding well, then that's a time to be an advocate and say, okay, let's step off the initial treatment because it's not working. Pediatric rheumatologists want to give our patients the opportunity to get off medicines if their disease is truly inactive. So it is reasonable to, when your rheumatologist says, I think we're ready to go off, to try it. But the minute that there is something that is a sign of a flare, we want to get on top of flares quickly and then decide, well, is it because we went off all the meds? Are those going to work for you again? Or do we need to do something different this time? We want to do what is best for the patient. Physicians know how dangerous these illnesses can be, especially if they're not adequately treated. And we're always thinking about risk and benefit. And an ethical physician will never want to put your child on a medication that in the grand scheme of things would do them more harm than good.